are very excited to be presenting our speaker today, Dr. Foluso Fakorede, who's a medical doctor and an interventional cardiologist in the Mississippi Delta. First, I would like to introduce Future Voices to you. We are a student-led organization founded in June of 2020. Our mission and our vision is to amplify the voices of underrepresented students and underrepresented populations here in the College of Nursing, as well as advocate for underrepresented and marginalized groups of people that we care for in nursing and in healthcare as a whole. We have very passionate individuals who meet every month, at least twice a month, to further perpetuate our vision and spread the word of things that we're doing in the community, which is things such as hosting events such as this to bring awareness of some of the healthcare disparities that we face. For example, the Black amputation epidemic that we're featuring today, as well as an array of other issues that underrepresented populations face. We hope to amplify the voices of everyone who feel disenfranchised and underrepresented. So if you know of anyone in the College of Nursing, please send them our way so they can join us in this mission and in this vision. Again, thank you for joining us. And without further ado, I would like to introduce our speaker for today, Dr. Foluso Fakorede, to grace us with his presence and his insight. He is a national voice in the fight against the impact of health disparities in underserved communities. His preventative initiatives, aggressive screening adaptations, and quality intervention strategies have led to a decrease in amputation rates by 88% over a 3-year period in his site of service in the Mississippi Delta. He was recently honored by the Root 100 Most Influential African Americans last year in 2020. We are excited to have you, and thank you for being here with us today. Please take it.
Greetings from Mississippi, Salwa, and thank you for that wonderful introduction. I am honored and humbled and excited to hear that we have very powerful voices that are in the forefront of advocacy and in providing quality care at the same time while obtaining your higher education. So kudos to you and your team. Congratulations on the formation of your new organization. And we look forward to sharing some wisdom that hopefully can help perpetuate not only the mission, but also expand its footprint beyond your local site of services. So thank you for having me. Just wanted to start off by, first of all, acknowledging that, you know, my mother's a nurse. And when I was getting my white coat, during my white coat ceremony in medical school, I only had one advice, not from a doctor, not from, you know, the dean. It was from my mother. And that advice was that, you know, in medical professional careers of doctors and physicians, nurses will either make you or will break you. and you know, I laughed when she first said that because, you know, not knowing what that meant, but it means that, you know, when you are a physician in the community or in private practice or in academia, and you have excellent nursing staff who care about the patient, who are compassionate, it makes your life easier on different fronts. And so I want to just give a huge shout out to every single one of you in the program. Proud of you. I'm an advocate, but now also I'm a fan. You know, I have wonderful nurses here as well who have helped, you know, enable, activate, and agitate all levers of power, both locally, regionally, and nationally, in speaking truth to power on this topic of preventable amputations. So I'll start the presentation with disclosures. I have none. So this is a graphic picture. This is what I see every day. This is a picture of patients who have what we call peripheral arterial disease, or its end stage, known as critical threatening limb ischemia or critical limb ischemia. The analogy that I use is cancer. It's like looking at stage 3, stage 4 cancer rather than stage 1. And if you look at all these pictures, these are patients who just took their socks off either in the office or in the hospitals, and I took pictures. Because when you want to speak about a virulent and preventable practice of preventable amputations, you have to have the world see the injustice that's going on, and how did we get to this stage, and how can we prevent this stage from occurring, and what are policies in place to prevent this, or what are policies in place to exacerbate this? So what's the clinical, economical, and human impact? And the X-ray picture in the middle that you see, this X-ray picture right here, basically right here with my cursor, this is a patient who's a diabetic who woke up and had gangrene, but unfortunately, before he made it to the hospital, his dogs had taken off the flesh off his toes. So that was not a blade, that's actually dog that ate his flesh. Sorry to be graphic, but that is real. This is what's happening in not only rural communities, but in a population where every 30 seconds a limb is lost due to diabetes and peripheral arterial disease in the world. But why does it disproportionately affect, African Americans, Hispanics, and Native Americans who suffer at a disproportionate rate? The fact that these patients have higher risk factors is one of the problems, but also they're less likely to get treatment. Which is called revascularization or angiograms, which is a process where you look at the blood vessel and you try and restore circulation and provide oxygen-rich blood flow to the blood vessel, so that that wound or that ulcer can heal, or that the patient can be alleviated of the symptoms before it progresses to a wound and ulcer. And this is just a table that we put together, just comparing what is the ratio in terms of African Americans versus non-Hispanic whites to African Americans versus Hispanics, and what are your chances of getting an amputation? And you can see it's disproportionately higher in people of color and marginalized communities. And to anyone who saw what happened with that video, 8 minutes and 46 seconds last year of George Floyd, you saw that there was a cascade of events that occurred after that, and people, industry, organizations, politicians came out, and everyone had a letter out to their employees stating that we're all one voice and we need to tackle racism, systemic racism. But all that did was, if you compound that with COVID, all COVID did, and what a camera did for 8 minutes and 46 seconds, is to unblind what has been going on for decades in marginalized communities and vulnerable populations. And so we need to understand what this is, why it is, and what we can do to impact this. As forefront providers, and if you look at rural communities now, nurse practitioners actually exceed the number of medical doctors or DOs that you see now. So you're at the forefront if you're a nurse practitioner and you go into a rural community, because that's all these patients get in terms of the first line of defense in healthcare. So you have to understand what it is. So peripheral arterial disease is a circulatory deficiency, which a prevalence of about 21 million Americans, mainly affecting the lower extremities, but can affect the upper extremities. So any major artery outside of your coronary system, which is your heart, that has some form of circulatory deficiency is known as peripheral arterial disease. It manifests with different symptoms that I'll get to later, but also it's very deadly if you have it. About 30% of patients who have peripheral arterial disease will have a mortality rate that's very high in 5 years. That's very concerning compared to cancer. If you compare it to most cancers, peripheral arterial disease has a worse outcome than breast cancer, skin cancer, and prostate cancer. So why do we fear it? It's slow, it's progressive. Most people have different symptoms, not necessarily asymptomatic. Atypical is the word I would use. It's different. They don't have all that pain that most people might present with in their lower extremities. They might just have burning, numbness, tingling. Your dialysis patients might just have to experience some symptoms during dialysis in their lower extremities, but can only share it with the tech or the nurse who's with them, and not the physician who rounds, once during their dialysis session and might miss that complaint. And then when these patients go home, they go home and their legs give out and they blame it on the arthritis or the gout, or as we say down south, the gouch. And when identified, it's usually too late. But most of these patients have a high co-prevalence of other atherosclerotic syndromes, namely coronary artery disease or cerebral vascular disease, strokes. So, which is the number one killer in these patients. So you're sixfold more likely to have one of those polyvascular syndromes. Do not forget renal vascular disease as well, kidney disease, which is a 30 to 50% chance. Significant morbidity and mortality in these patients, as I've mentioned, but also it's extremely prevalent, and the numbers are on the rise when you look at the two most intriguing, unique risk factors that will plague our healthcare system for decades to come, namely diabetes and obesity. 48 to 50% of African Americans share one risk factor for cardiovascular disease. We have an aging population where octogenarians are the fastest growing population. And we have an increasing diabetic population where 1 in 3 adults will be a diabetic by the year 2050. Are all these patients who are at risk for getting peripheral arterial disease getting screened as we speak? No. Are their death rates similar or higher than cancer? Yes. Do we have a fortified and a great screening system for cancer patients who are at risk? Yes, we do. But we lack that for PAD. So PAD is the most prevalent, most costly, most deadly, and disabling disease that most people have never heard of. And these are just to highlight some of the disease states that you see with PAD. You see smokers, but not just smokers, people who have nicotine exposure. If you dip, you chew, you vape, that should be under that spectrum. So when you see a patient, don't just ask them if they smoke. Ask them, do you dip or do you chew? And that's prevalent, especially in the minority population, African Americans who grew up, especially in rural areas. Affording a cigarette was something challenging, especially in poor communities. So dipping and chewing is an alternative, and that too can accelerate their atherosclerotic burden. Kidney disease, diabetes, and advanced age. And here are some of the risk factors that we've talked about. Those risk factors are being overweight, physically inactive, having high blood pressure, and for the most part, African Americans will carry the cardiovascular burden for decades to come if you look at shared characteristics, irrespective if it's male or female. But what we're seeing now is that female are carrying actually the higher prevalence of peripheral arterial disease. My practice being a perfect example. 60% of the patients that I see in just the African American population are females who present with PAD, and they're largely ignored. And why are they ignored? Well, we'll discuss that later on. But if ignored and untreated, it can lead to an amputation. And each year, there are more than 160,000 amputations that are performed. About 65 to 70% of these amputees are diabetics. And if you go to see their records and you determine what preventative strategies were implemented before they underwent an amputation, about 55% of them never had an appropriate timely screening with an angiogram, which is where you look at the anatomical arterial flow of the blood vessel, and you determine if it's blocked or not, and you send them to a specialist such as myself who can unblock that artery, or you send them to bypass surgery where a surgeon can do a bypass before an amputation. Well, most of these patients are offered an amputation first strategy 55% of the time. Well, in the Mississippi Delta, that is 90% of the time. That is unacceptable. And that is why I'm here. That is why I moved here. For those who wanted to know how I ended up in Mississippi, I had to, as an African American who represents, we're less than 10% minorities in medicine, but less than 5% Black physicians in medicine in terms of cardiologists. I represent less than 1% as a limb salvage specialist and also as an interventional cardiologist. Mississippi has the highest percentage of African Americans per any other state, but has the least number of physicians per capita. And majority of these patients look like me. And we all know what the data says. If you go to a town or community where your patients look like you or that diverse like you, they're more likely to not only adhere to medical follow-up, but also it facilitates care-seeking behavior. So that's why I came here. I took a chance, moved down to Mississippi with God's blessings and came here and tried to affect change. So what did I learn in the process? I learned that this is part of the amputation lottery. The probability of undergoing an amputation in America depends on the following. One, if you're a minority. Two, if you're older. Three, if you are more female than male. Four, if you live in a rural area where you have less specialty care. So you have less specialists who can treat your diabetes or all those other risk factors for peripheral arterial disease, heart specialists, or if they lack vascular care specialists, and if they lack podiatry care and good wound care. But also, if the hospital system doesn't have policies in place to have limb preserving strategies, then you're at risk. And then your social determinants of health or socioeconomic status also plays a role. And these eventually lead to bad outcomes when it comes to cost, not only to the hospital, but to our healthcare system. And majority of these patients are minorities. So this is an example, it's a map. This map, if you look at the population of slaves before the Civil War, it actually mirrors the Black census scope of America. Majority of the Black population in America right now are located right here. But majority of the amputation rates, if you superimpose that, are also located in the same region. And the least likely place that you can be where they perform the lowest number of revascularizations are also in the South. So for those who want to know why we have an amputation epidemic and why you're 3 to 4 times more likely, well, here's evidence number one. We also have obesity that can lead to diabetes, and look at the states. Mississippi has been in the top 3 for a while. But here's the statistic that's shocking. You know, as much as we have all these high levels of diabetes, Mississippi also has one of the lowest number of endocrinologists. There are less than 10 endocrinologists in the whole state. I know you guys live in Colorado, Denver, right? Around that Denver area. I bet you, if you were to compare that to Denver, probably in a 3 to 5, mile radius, you can find 8 endocrinologists. Well, you can't do that here. And so we, in terms of African Americans, carry the highest rate of cardiovascular disease in terms of prevalence. But the Hispanic population also will catch up eventually, and Native Americans will as well. And these numbers projected by the American Heart Association are only growing. So you have to understand the trends. We have a growing population, aging population, increase in prevalence of chronic disease. We have changes in our testing and procedure utilization that we all have to know. We're going to value-based care. We have an aging cardiology healthcare workforce with a average age of about 55. Projected primary care shortages, that's where nurse practitioners and other providers and PAs come to play. And lower percentage of minorities who are going into medicine, or going into nursing, or going into other allied health fields. And then look at the number of physicians or providers per capita. These are things to understand. An example being why Mississippi is high with amputations, but also diabetes, is because it's the only state that has all its county represented in the diabetes belt, all counties. Diabetes, what does it do to our circulation? Well, it makes people present with more severe disease or level of disease known as ischemia, which is the interruption of circulation and lack of oxygen-rich flow to your extremities. Ultimately leads to ulcers and gangrene, so you're more likely to present with that early on as a diabetic. You have critical limb ischemia, which is what I just described, basically. You're more likely to undergo an amputation, and your rate of amputation increases not only with the severity of your diabetes, but as you get older. Unfortunately, we're seeing diabetics now die younger, but that affects the heart, and they die at a higher rate from cardiovascular outcomes and cost. It's a very expensive disease state. So it increases your chances of undergoing an amputation by 4-fold. I've already mentioned that majority of these patients will not have a pathway to a limb preserving strategy, but rather to an amputation. And African Americans carry that risk in spite of all the advancements that we've seen in technology and also in medical therapy over the last couple of decades. Look at all the tools we have in medicine, all the medications that have come out, but we've seen a higher rates of amputation and death rates in our most vulnerable population. Our healthcare system is fractured, and costly. It costs more to amputate than to save the leg, but hospitals prefer to amputate. Why? That's another question. Annual cost for peripheral arterial disease exceeds that for diabetes, coronary disease, and cancer. What are some of the symptoms? So when a patient presents to your clinic or your office and you're seeing a patient for the first time, the first thing you need to do is to take off their socks and ask for symptoms. And these are some of the symptoms you ask. And I'm not going to go through all of them, but the typical ones are tiredness, heaviness, cramping, or pain that disturbs your sleep, any discoloration in their color of their skin, any wounds or ulcers, and is one foot cooler than the other, and do they have any symptoms that are consistent with arthritis that are mistaken for other diagnoses other than PAD. And then we have a classification. Whenever you have rest pain, an ulcer, advanced ulcer, it's like having a heart attack. That's the analogy. And when a patient has a heart attack, we don't just sit there and watch, right? We call 911, take an aspirin, go to the emergency room, and hopefully you see a cardiologist that puts a heart stent or does a heart catheterization and unclogs the blocked artery. The same thing has to happen, and same sense of urgency has to be there for the lower extremities. Why? Because these patients have a threefold higher chance of having an acute myocardial infarction, which is a heart attack, stroke, or vascular death within a couple of hours. And 40% of them will have an amputation within that time frame. So here's just a little pie graph that shows that most patients present with atypical symptoms. That's why it's important to check their pulses, take off their socks, try and elicit a pulse if you can. So history and physical is important. And next is to do an ankle brachial index, which is where we basically look at the vasculature and compare the ankle and the brachial pulses and do a fraction, blood pressure correction, blood pressure, and we do a fraction of that. And if you're over a certain number, we have to determine if you have disease or not. There are certain patients that we have to be cautious with an ankle brachial index, and those patients are if they've had history of diabetes or history of calcium seen on X-ray, or if they have end-stage renal disease. Their vessels are not as compressible, and therefore you can get a good reading in terms of ankle brachial index. Also in the population that are older, over 75. So you have to be very cognizant of that. And then smokers as well. What are some of the treatment options? Lifestyle, dietary, changes are number one, right? You quit the bad things first. You quit smoking, quit dipping, no chewing, lower your blood pressure, treat your cholesterol. Get that A1C down, drive it down to less than 7% if you can. Healthy diet, they have to be educated at their literacy level as to how to eat right and how to live right. Medications have to be not only prescribed, but can they afford the medicines you're prescribing? Can they see a specialist if they're having a hard time managing their conditions, namely diabetes or blood pressure? And do they need to be on any other therapies? It's a multidisciplinary effort, and this is where nurses come to play. I mean, nurses are the best at implementing these. In terms of, seeing a patient from the time they walk into a clinic to when they go home. And nurses give out their phone numbers. My nurses will give out their phone numbers and say, call them. Those are things that actually are altering to a patient because someone actually cares about them. It's compassionate care. And the last piece to it is the procedures: revascularization, angioplasty, which is a balloon, stenting, which is a metal scaffold, atherectomy, which is basically displacing the plaque, or bypass surgery. And this is, for those who think that we just use dye in the lab on the left, we can use a gas called CO2 in our patients who have kidney disease. So when you're in the community and you hear a patient has kidney disease, you should ask for CO2 angiography, which is another way to look at the blood vessels without hurting or exacerbating their renal dysfunction. CO2 angiography. But prevention is better than cure, as we've been told, right? So we need to implement better strategies at starting antiplatelet therapy, statin therapy, and also exercise, supervised exercise testing upstream. And also, as I've mentioned, telling our patients to stop smoking. We do a poor job of doing this as a whole. And our nurses and nurse practitioners actually are better at trying to get our patients to listen than actually physicians, interesting enough. Patients find them more relatable. So this is a patient of mine. This is my nurse practitioner and I, while we were filming for the ProPublica article, but also we had an NBC Nightly News shoot that night. So this was in May of 2020. I bring bad news to you that this patient here actually died yesterday. Unfortunately, she had been amputated 5 years ago, and she remained a smoker, and she passed yesterday. It was sad, and I had to include this picture because just to let you know that 80% of patients who get amputated are dead within 5 years. And you know, she was a sweetheart. Her family was sweet, and you know, we're checking her pulse, inspecting her feet. That leg was good, but she had already been given that hourglass when she had an amputation 5 years ago. So who are the at-risk populations? Anyone who's less than 50 with diabetes and one additional risk factor that's listed here, smoking, high blood pressure, high cholesterol. Anyone who's between 50 and 69 that has a history of diabetes or smoking or nicotine use. Anyone who's just over the age of 70, about 1 in 3 of these patients will have peripheral arterial disease. And then anyone who has symptoms or anyone who has a diminished pulse on exam, anyone who's a minority should be screened. But we also have to understand that there's social determinants of health. Can these people actually access clinics to get screened? Is transportation an issue? Is income an issue to afford the bills or the copay to see a doctor? That's why the type of clinics we have in this environment are good. We shouldn't just have for-profit hospitals across the whole entire rural America. No. What some of the challenges they face in terms of housing. We're seeing that now, even with social distancing in COVID era. These patients can't afford to do that. We said that they should go and exercise. Well, is it safe for them to go outside and exercise in their neighborhoods? What is the literacy level of your patient? When they walk into your room, do they understand you? Do they understand what you're saying? Do they understand the pamphlet you gave them, or even the consent forms to sign? So those are things that you have to be cognizant of. And then food deserts, access to healthy options. That's a huge issue in rural America. And not to mention the community and social context of not engaging the community. We're big community navigators. We go out and engage the community, engage the faith-based organizations that are the pillars of strength in this place. Women-based organizations, women-run organizations are the pillars because they're more aggressive in terms of health preventative strategies. So we engage them. But we also know that there is discrimination and implicit biases that occur in medicine. We just have to call it what it is, all right? And then health coverage. Do your states take care of the uninsured Medicaid population? And also provider competency programs in place or availability in place. And it's not just access to care, it's access to quality care. Because that first line of presentation or that first line of care will determine if that patient lives or dies. So we have to understand that social determinants of health is what's needed so that our patients don't suffer from the evils of amputation. Namely, majority of these patients do not walk after an amputation. They have significant decreased quality of life. Their death rates are very high. Majority of these amputees are not discharged home, so their medical bills are high. They require assistance. The cost to take care of an amputee lifetime is about $500,000. And the median income of these patients are about, what, $32,000 to $35,000. So most of them also live with high chronic pain. So what we did is we as Sawa mentioned when I came on, we took a holistic approach to identifying the risk factors of these patients, looking at their physiologic and socioeconomic statuses and documenting just our journey. And I was fortunate to collaborate, and my nurse is actually was listed on this as one of the co-authors. And we showed how we decreased amputation rates by 88%, being aggressive, timely screening, timely treatment, and being a champion and advocate for these patients. Here's what population screening can do. You can identify patients. This was a patient who had diabetes and a stroke, but she was wheelchair bound. Everyone attributed it to her stroke. She was screened at an event that we held in 2017, one of the largest population screening events in the country to date. And what we did here was, before, she had 0 blockages. She had 100% blockages in her arteries right here. This pipe should just go and connect, but it's not. And you see it after. 45 minutes later, we connected it. And she's standing in my office 2 weeks later. So these are just examples of what population screening can do. But there are people who have a problem with population screening or at-risk screening. And that task force, which is the U.S. Preventive Service Task Force, is a task force that was established by Congress in 1984. And the job of the U.S. Preventive Service Task Force is to be, that guideline for providers such as yourselves, and for providers like, who are primary care providers, who are going to be in the forefront looking at these patients. And they give them what services based on evidence-based recommendations about preventative services, and should they be covered by Medicare or Medicaid. Now, there's a huge debate. Have they mistargeted the population, misdefined, or missed the evidence? Because they have to date yet endorsed screening for peripheral arterial disease for at-risk patients. The American College of Cardiology, American Heart Association, My Body, we recommend it. But the U.S. Preventive Service Task Force does not. There are more primary care docs than there are cardiologists and vascular specialists. So those patients will forever see these patients before, these doctors and providers, before they come and see me. So they need to be screened. And so their comments, which are interesting, quotes, and this is what I highlighted here. Sorry, it's a little bit blurry, but I'll read the comment. The evidence that the prevalence of PAD is disproportionately higher among racial and ethnic minorities and low socioeconomic population is true. And they note that their statement, which is insufficient evidence, could discourage testing and perpetuate disparities in treatment and outcomes. Very powerful. They endorse that, yes, this will lead to worse treatment and outcomes. However, they say that they also recognize these well-established disparities in care. However, the evidence on screening and treatment in these groups, so these groups are minorities, are currently lacking, and we're unable to determine the overall balance of benefits and harms. If I stop this presentation right now, based on everything I've told you in terms of minorities and what we've seen, you're telling me that a bunch of physicians, 12 to 16 men or female group in a room, none of them are vascular specialists, cannot determine that there are at-risk populations for amputations that need to be screened? That is unacceptable, and that's what a systemic policy that is flawed will do to ruin and to perpetuate worse outcomes in the most vulnerable population. So let's look at one of the big trials that came out. Big trial for a drug called Xarelto vascular dose, 2.5 milligrams BID. We use it in our space. They studied 27,000 patients. They could only find 200 African Americans. I just told you who carries the largest burden of cardiovascular disease. That is an example, because studies like this will feed policies, will feed outcomes, or feed how we prescribe medicines. And that is wrong. And if you look at all clinical trials to date in the cardiovascular space, only 5% of clinical trials have included African Americans, 1% Hispanics, 12% of heart attack trials have included elderly, women, only 33%. There is a problem. And there is the most disturbing part of this recommendation is that in spite of them ignoring peripheral arterial disease that's so prevalent and deadly, hepatitis C gets a B recommendation, even though there's no direct evidence that the benefit of screening every person that walks into a primary care doctor's office needs a hep C, nor is there a screening for alcohol misuse. So anyone over the age of 18 should be screened for alcoholism. PAD should lead that. So when you're pissed off, just as I was, what you try and do is you realize that, when you feel that your belief is strong and your mission is just and that your purpose is just and obstacles shouldn't stand in your way, you have to wear an advocacy hat. And as Martin Luther King said, morality cannot be legislated, but can be regulated. So decrees are put in place so that you don't change people's hearts, but you restrain the heartless. The example was at the time of lynchings, you may not love me, but you will not lynch me. So here again, the example is that you may not like me or love me, but you should not amputate my limbs. So I got involved. This is a patient who I took to Congress in 2018. She lost her first left leg in 2015 and lost her second leg in 2017. She came to my office and took off her socks, and I knew it. I mean, it was the first time, and I knew she was going to lose that limb. It was just black. She was one of those pictures I showed. She lost a limb, and I told her to get involved in advocacy with me. Her name was Mrs. Gertrude Campbell, and I'm sad to report she died last year, 5 years after her last amputation, after her first amputation. But Congressman Payne Jr. Listened to her and loved her story and wanted to become an advocate. So we started this whole campaign to not only raise awareness, but also to educate and to try and get the powers of levers in the congressional caucus to form a PAD caucus, which was formed. And with the help of the Cardiovascular Coalition and other members and stakeholders were able to successfully do that. That also led to more publicity in terms of coming to talk about the Black American amputation epidemic and being featured. And it led to the introduction of legislation called the Amputation Reduction and Compassion Act. And basically what the main provisions are as follows, is to establish and coordinate educational programs, to also facilitate and establish coverage for PAD screening without the cost sharing. So everyone who is at risk should be screened without any cost sharing, regardless of your insurance status. And it requires some development of quality measures through HHS, but also we should disallow payment for non-emergent amputations who do not perform anatomic screenings before the amputation. That's important. And why is that important? Because I also need to come back and educate not only medical students, but nurses, nurse practitioners about how we got here and how vascular disease is something we don't talk enough about in our training programs. And that's important. So the call to action, as I wrap this up, is as follows. We should form partnerships, multi-disciplinary partnerships. This is one of them. This is a perfect example. We should have community-based participatory research and translation. And therefore, when you have programs, go into the community, engage them, and meet them where they are, and use that as research data, right? Because that facilitates trust-seeking behavior, and they come to you. And then you are able to translate that data for your colleagues who are not familiar with that population. Then you accelerate the health impact of those disparate populations, and you advance policies and systemic changes, but also ensure that you have diverse clinical and public health workforce. And that goes to not only academic institutions, but societal institutions as well. Access to quality healthcare across the entire spectrum needs to be incentivized. We need to get specialty care here. God bless Doctors Without Borders, but there's a lot of rural care that needs a lot of specialty care and attention here in America. We should incentivize that. Also, we should shift the delivery of care from inpatient hospital to outpatient settings where it's cheaper and more affordable and patients like it better. And try and come up with policies to disincentivize bad behavior, especially in rural areas. And do we justify sugar taxation, for instance? It's worked in certain cities. It's debatable, but that's something to think about. And medical and nursing schools must initiate comprehensive PAD curriculums and address the recruitment and retention of specialty care while advancing other policies. So as in conclusion, this is the I Have a Dream speech. I think that we want rural areas to become an oasis of health equality and community-driven initiatives. And it all starts with great nursing. So thank you for your time. Be compassionate in everything you do, because the difference between empathy and compassion is what you do after you empathize is to act, to get involved and be an effective communicator, but also to do something about it. And for me, it all starts with knowing that we all carry this apron of humility in our titles, And medicine, encompasses the power of mankind to do good, to heal, and to be humanistic. Thank you for your time.
Thank you so much for that wonderful presentation. We're just going to open it up now to a few questions. So does anyone in the audience have a question for our wonderful speaker?
I have one that came up while you were talking. Thank you so much. That was an incredible presentation. And as a graduate student, we have to do a lot of research classes and we follow the USPSTF guidelines for everything. So to hear that and to realize that, I think it allows us to kind of take a step back in terms of like what those recommendations look like and to consider where they're coming from or who's kind of enforcing that and who's not having a voice in that should. So I really appreciated that aspect especially. Something for me that you had mentioned was that for you, I think going down to the South, you said patients that you were someone that looked like them. So they're able to adhere and to follow up. And that you said also that like nurses and NPs are more relatable than doctors, which I've heard many times. And I know it makes me feel a little bit better because I feel like doctors have like more knowledge to start off. But I was curious for someone who doesn't necessarily look like my patients and for this being disproportionate BIPOC patients, what can we be doing, I guess, to help them better adhere and to relate with them in that regard?
That's a great question. I mean, it's if I were to open this door behind me and you would see my staff, it's split in the middle, right? It's the initial nurse who actually does most of our community activism and outreach program is from Colorado. A blonde hair, blue-eyed girl from Colorado who came to the Delta and realized that, these people needed a true education, inform to transform is the lingo we use, right? So you have to become an advocate for them. But to do that, you have to understand that and learn that and accept the fact that one, there are systemic and systematic issues in how the distribution of power is in our, not only in our healthcare system, this is pervasive in other areas as well, but it affects the outcomes of these populations. If you accept that and you're no longer in denial and you know what racism is or biases are and you understand that, and if you're part of that minority, women in general are part of that minority, just FYI. But if you are part of that minority, then you can go in and then understand and talk to, engage them and try and be a good student in learning what are some of the cultural issues and the strengths and weaknesses of this community that I need to learn, and then come back and try and bring your flavor to it in terms of what you do. Because what they like is they like the fact that, you engaged, you were humble enough to take away and undress all this titles that we carry on, the white coats and the stethoscopes. No, just come on in and just be yourself and be human, because being humanistic is the first thing you have to do. And they have to see that. It has to be palpable. And the second thing is you have to collaborate with community navigators, people who understand that community, and go in tandem with them and understand how to navigate. Once you understand how to navigate that community, then you can now go back and form policies and then bring your navigators with you. And they give you and they embolden you because they give you credibility. And you can then independently at some point bring others with you, because that lens is what you use to go change others. It's just like the civil rights era. It wasn't all African Americans that changed that, right? Emmett Till was murdered 30 miles from where my office is right now, and Money, Mississippi. But it's until white folks started saying, hey, wow, this was unacceptable, and came down here, and that was the impetus for the civil rights movement, right? It was when Black and white people got together. Same lens has to happen in medicine. And what we're seeing right now is that we have our academic lens and people just paper pushers, and you guys know what I'm talking about. Let's write this research. Oh, it's not racism, it's biological. It's, it's something other than what it is. No, it is. There is a difference. There's a zip code geographical difference. Environmental racism is real, geographical racism is real. And we have to go and accept that in what we do and how we communicate with these communities.
So we have a question in the chat from Julie. They say, first of all, this was the most inspiring presentation I have heard in a long time. Thank you so much. We have some rehab folks who are watching, and my question is about allied health professionals. How do you see our role as physical therapists,
Yes, yes.
in preventing amputation for vulnerable populations?
As I've said, the first thing they need to do is when they see any patient, what do? Check their pulse, take off their socks, right? So if you know they're diabetic, or you see that they're having problems, or that wound is not healing, or they have problems with ambulation, or they just had surgery, because what's sad is that 30% get amputated need a revision proximal to that amputation stump within the first year. Another 50% will have a contralateral, meaning the other limb will get amputated within the next year or two. So physical therapy is very important. And two, they serve as comfort because they spend a lot of time with these patients and understand what challenges they face at home. So what's missed in the clinic can be also garnered in physical therapy, and communication with the primary care team to relay what the challenges are, but also to recommend, hey, y'all might want to look at the circulation of this patient who I've been seeing for a while, because I just looked at their feet and just the pulses are diminished. Simple things like that help, because that can ultimately save a limb and save a life in that process.
I have another question in the chat. For PAD, at what point do we stop prescribing SNRIs, gabapentin, etc., and refer to you for intervention?
Right. I would save the SNRIs for people who they think have neuropathy, right? So for a patient who you think has gabapentin, or, most of these patients will come in with gabapentin that I see on initial visits, and especially if they're diabetic or allergic or whatever, you name it. Majority of these patients can have different forms of neuropathy. Is it ischemic neuropathy or diabetic neuropathy? We don't know. Guess who has to determine that? I need to rule something out. I'm the vascular guy. I need to rule out if it's ischemic neuropathy. Is it large vessel neuropathy? Is it small vessel neuropathy? Do they have back pain that's causing this, right? There are things that we have to look at to make sure that it's arterial in nature. And then there's venous disease, which I didn't talk about. The most chronic medical condition in America is venous insufficiency. So a vascular specialist can put the two together and tell you what it is and what it's not before we start prescribing medicines. Why? These medicines, the efficacy of these medicines are not great. 1, 2, side effects are crazy. And 3, they're expensive. Well, again, Lyrica is an expensive drug. And so these patients are limited, and our job is to minimize the cost to them and to their families.
Another question from Justin. Earlier on, you said that amputation is actually more expensive than treatment, and I missed the reasoning for that. Is it just the long-term cost associated with not treating the disease in the first place?
That's a great question, Justin. So the cost for an amputation in hospital cost, $40,000 is part of that, and it's $15,000 to $16,000 less cheaper to do a revascularization or to do a bypass, so to restore blood circulation. That's one. But I just told you about the evils of amputation. Majority of these patients cannot ambulate. The cost of a prosthesis, I don't know if any of you have looked at the cost to get a prosthesis these days. Medicaid does not even cover it. We're talking about things that are between $20,000 to $70,000 for some patients, right? And then majority of them will stay in a nursing home, and their family members will have to come out of the workforce to take care of these patients. These patients need to have ramps in their homes. They need to have new transportation modes. I mean, let's just stop there, not to mention chronic pain. And then the revision is that surgical revision procedures. So if you can lump all that up, and the chances of them having an infection or dying during any surgical procedure, the cost of our healthcare system, as we've looked at, is just too tremendous when it comes to the first strategy, which is the amputation first strategy, excessively higher, not to mention more deadlier.
And then it looks like Patrick has a question for you. Patrick, do you want to ask?
Sure. Thank you for coming and being a part or for presenting. It's been enlightening and amazing, and I think a real call to action. One thing I wanted to point out is our campus, where we're at here in Aurora, which is the most ethnically diverse area of Colorado. So our campus is kind of what, you know, you mentioned an oasis. I kind of get that feeling because our campus is in a food desert. There's not a grocery store within a mile of any direction of where we are at. The immediate population that's directly around our campus is kind of looks up at this large medical center as something foreign. I mean, there's no parking. There's not a. I mean, they enter through the ER, and a lot of times they don't see what's behind those doors.
Right.
My question for you is, you know, I'm the faculty liaison for the Future Voices group, and we're trying to get a lot done, and the students are very motivated.
Right.
Just strategies. What strategies would you recommend just to connect to our community?
I love it. This is, now you got I'm in. I'm all in. All right. So here's what I would do, because I don't know if the plan is to bring the patients or the community to you. We have to take it to them. And what I would do is, so you have to figure out, for instance, so the food deserts. In my practice, you know, my nurses are, you know, healthy. I mean, they eat right, especially the ones who I take out to the community. They're all about like, hey, let's teach you how to eat right, right? And so what they'll do is that when they go out to the churches or the faith-based, they'll actually sit down with them and explain how you can go to Walmart, because we all have a Walmart or Kroger. Every rural area has one of the two, or Dollar General. And they'll explain to them how to shop, like what kind of foods to get, right? So we don't have to be in that fancy area where the calorie count is on the wall or on the glass. No, and then two is to have, you know, scheduled meetings with them where you can show them now how to eat, but now how do we cook together? So we have cooking sessions. Three is, and you can have that on campus or off. It just depends on the modality and what's available in terms of site selection. But within that setting too, you have to have a physician champion who can be comfortable in standing in the pews of where a lot of these people are. Here in the South, it's churches. So that's where I hang out. You know, this is how I roll with the t-shirt. I just roll in there, and because I tell people, you know, you give your heart to God, but if you don't have a healthy heart, mind, body, and spirit, we have a problem. Same things with your other, you know, other systems where they all work in concert. So it's just to be able to relate to them that, you know, we care about you, want to love on you, but we need the champions to go out and take chances, because that's the thing. You know, it's one thing to say we're hosting a health fair and to let them come on your campus. Majority of them will not come. It's time consuming. It takes them away from their Friday night lights. It takes them away from, you know, things that happen on Saturday when mom has to shop for all the kids. Sundays, they're all stakeholders are in one place, and I found that very useful here. That might be different where you are, but that's, for me, that's what's worked. And then, you know, we have events and we have giveaways where, you know, they're like, hey, doc is coming, we'll have games, healthy, you know, health, you know, health related channels that we show them when they come to my office. You know, I show them graphics as to, this is what bad plaque looks like. Here's an example. This is clean arteries. These are what happens when that diabetes and that sugar and that nicotine and tobacco is, right? They see it and they're visual and they get it. But you have to make it a constant reinforcement to go out. And you have to have the support of your medical community to buy in. I'm doing this by not only by myself, but my Mississippi Hope, which is a nonprofit organization that helps support my outreach adventures. Hospitals are just not big in terms of going out to the community. So it's up to the gang here. We're the ones who have to do this. We're the SEAL Team 6. I use the military analogy, right? We have to do the dirty work first, and then the brigade comes after.
And I know you have another meeting, so we won't keep you any longer, but thank you so much for your time and for educating us. We really appreciate you and
I
everything.
look forward to coming back. Please invite me back. And hopefully, you know, post-pandemic, I'll come and visit and be engaged. Patrick, I owe you guys a visit and come and, you know, we'll do a community event, hopefully. All right?
Thank you so much.
All right. God bless. Take care. Bye, everyone.
Thank you.
For everyone else typing in our website in the chat, feel free to follow us so that way you can keep up with our events coming up. Thank you.